So Dr. Lara Bryan-Rest is a radiologist with Cape Cod Healthcare who specializes in all aspects of breast imaging and related procedures, including mammography, ultrasound, and MRI. She attended the University of Pittsburgh School of Medicine, where she participated in a special training program in women's health. She did her residency and fellowship training at Yale New Haven Hospital, which included additional training in breast imaging and interventional radiology. From early in her medical training, Dr. Bryan-Rest was drawn to the field of breast imaging and interventions because of the direct role she would have in caring for other women. Sometimes breast imaging can be complex and anxiety-provoking. Dr. Bryan-Rest compassionately helps women navigate those experiences. Today, she will speak about advances in breast cancer screening. Dr. Bryan-Rest.
Good afternoon, and thank you everyone for coming today. Thank you, Julie, for the nice introduction. And as Julie mentioned, I'm going to be talking about advances in breast cancer screening. A little bit more about my background. One of the reasons that I was drawn to breast imaging from an early age is that my mom was diagnosed with breast cancer when I was in high school. And that was in the early 90s. So I've watched the progression of how breast cancer has been, at that time, anyone who may have had anyone affected with it, that was a time when we didn't say the word breast cancer in public. We weren't allowed to talk about it. And there's been so much advance in the diagnosis and treatment of breast cancer that it's really been amazing to see throughout my professional career. Today, I'm going to talk about a couple of things. First, screening mammography. There's a lot of confusion and conflicting information about who should have screening mammograms, how often. So just wanted to touch a little bit on that. That could be an entire day's conference, so I've really tried to highlight the key points. Then going to talk about advanced imaging technology so that you know what's available. And all of this is available on Cape Cod, so you don't have to leave the Cape to get advanced imaging if you need it for your breast. Also going to talk about our high-risk hereditary cancer program. And at the end, resources that are available to you. It's the one part that it's all in the handout, so if we don't get to it, it's all listed there. So in terms of screening mammography, I'm going to talk about breast cancer by the numbers, talk about the guidelines, and then talk about what some of the arguments are against annual screening mammography. The references, and I've put them in there if you're a numbers person and you want to see the studies. All of the numbers that I have are from this article, which is only a year old, September 2017, from the American College of Radiology. It goes through what their recommendations are, how they got to them, and it gives you all of the references for the studies that come up with these, that have given these numbers. Another great resource for patients is End the Confusion. It's a website put out by the Society of Breast Imaging. It has a great ebook and actually has a great little video vignette at the beginning, which I encourage you to watch. So breast cancer in the United States is the most commonly diagnosed cancer, if you exclude skin cancers, in women. And it's still the second leading cause of death in women in the United States from cancer. In 2017, there were over 300,000 cases of newly diagnosed breast cancer, and we still had over 40,000 deaths from breast cancer. 1 in 8 women will develop breast cancer in their lifetime. And I included the slide, the facts about women in their 40s, because that tends to be one of the areas where there's a lot of confusion about should women in their 40s be screened, how often. 1 in 6 breast cancers occurs in women in their 40s. 1 in 69 women in their 40s will be diagnosed with an invasive breast cancer. And when we look at the years of life lost to breast cancer, it's 40% of years of life lost to breast cancer is women in their 40s who are diagnosed with breast cancer. The other thing that one thing I commonly hear is, I don't have a family of breast cancer, so I really don't have to worry about it. 75% of women who are diagnosed with breast cancer have no family history of breast cancer. Another thing that I hear is, oh, I'm 75, I don't have to worry about breast cancer. And that's not true. The risk of breast cancer increases with age. Since 1990, the death rate from breast cancer has decreased by nearly 40%. And all of the studies have shown that much of that decrease is because of annual screening mammography, which is finding cancers early. An important fact is that 75% of women who die from breast cancer don't have routine annual screening mammograms. Just trying to highlight the importance of why screening mammography is important. The recommendations from the American College of Radiology are annual screening mammography starting at age 40 for women of average risk, and I'll talk a little bit about risk towards the end, average risk of developing breast cancer. So another common question I hear is, well, when do I get to stop having mammograms? And there's no magic number, there's no set age, and the considerations that are important to talk about with your primary care doctor is, what's your overall health? If you're in overall good health, you're healthy, active, you would continue screening. Also, if you would consider seeking treatment if a cancer is found. If you say there's absolutely no way I would have treatment, then there isn't a point to do screening, although I put the caveat that I've had a fair number of women that say that, even if you find something, I'm not going to do something, but when they find out that they have a cancer, they do want to find what the treatment options are. And cancer treatment today is not one size fits all. And a lot of factors are taken into consideration about what can be done to minimize treatment effect and patient's age and overall health. And I put the last one in italics because this is doctor speak, and I don't really like this, and this isn't what I say to patients when they ask me. But in the medical world, it's if a patient is expected to live 5 to 10 years. And it makes me think of a story that my parents are in their 70s, and they recently needed to buy a new mattress. And they went to the store, and the salesman was trying to upsell them. Oh, get the more expensive mattress. And he said, oh, this is the last mattress you'll ever have to buy. Thinking, well, because you're old and you're not going to have to buy another one. Well, that wasn't really what inspired my mother to want to spend extra money on a mattress, because it was one of those moments where she had to think about her mortality. Not something a lot of us want to do. So when patients ask me, what I tend to say is, well, how healthy are you? How's your heart? How are your kidneys? How's your liver? What else is going on in your overall health? If you're pretty healthy, you should keep coming to see us. Other important things to consider in that when do I stop? Cancer detection rates are highest and recall rates are lowest in women over 70. And older women who don't get screened, because we know that they're still at risk, tend to present with more advanced cancers and have reduced survival. So what are all the arguments against annual mammography? And one of the important things to remember is all of the different societies that have all these different guidelines, they all admit and they acknowledge that screening mammography saves lives. But these are the major arguments that they put out as to, well, risk and benefit. And one of the major reasons that they argue against annual mammography is that there are false positive events. A false positive event is when you have your screening mammogram and we have you come back because we see something that we want to look at more. And you come back and we say, there's nothing there. So that's a false positive event. We've increased anxiety, we've brought you back, but there's nothing there. And for women who have annual screening mammograms, this happens about once every 10 years. There's also a false positive event if we see something, you come back in, we see something on your screening mammogram, we have you come back in for additional imaging, and we do find something, and we recommend a biopsy. But the biopsy ends up coming back benign, that's considered a false positive event because it wasn't cancer. That happens in less than 2% of women who are screened. The other, and one of the major considerations, particularly for the United States Preventative Task Force, was an issue of anxiety. Because it's anxiety provoking for a lot of women if they get a call and if they've always had negative screening mammograms and they get a call and they get a letter that says, we've seen something, we'd like you to come back in, there is anxiety. They've done surveys after this came out to find that 86% of women accept that anxiety knowing that this could detect a cancer earlier. Knowing that coming in and that sometimes we're not going to find anything, but it gives us that opportunity that if there's a cancer there, we're going to find it when it's small and more easily treated. And the last one is another big topic of overdiagnosis. We're finding the statement, we're finding cancers that don't need to be treated, which the studies, it's a hard fact to prove or disprove. Literature says the highest percent of overdiagnosis would be 10%. The problem is we don't know which cancers. We don't know which cancers are going to progress quickly, progress slowly. We know that biology is a normal cell to an atypical cell to a cancer cell. We know that, and we know that at some point the cancer cell will spread outside of the breast. We can't predict an exact timeline, and this is our best diagnosing it and treating it, particularly when it's small and most easily treated, is our best way to make sure that a woman does not have breast cancer be the reason for her mortality or morbidity. So one of the things that has happened in order particularly to address some of the concerns over screening mammography is that we've had a lot of advances in imaging technology. So the three main ways that we're able to look at the breast are through mammography, ultrasound, and MRI. And we're also able to do image-guided biopsies with all three techniques if we see something that needs to be addressed. Digital mammography, this was a big topic probably 10 years ago. Before digital mammography, everything was a film where they'd go and take the picture and then they'd go in a dark room and they'd have it printed. And then in 2005, there was a big trial that showed that we can move to digital mammography, and it's as good. Digital is, so it's all computer. It's taken out, pictures taken on a computer, everything's stored on a computer, and the radiologist looks at the image on a computer rather than a film on a backlit film box. And what that trial showed is that digital mammography was as good as film mammography, and then for some women it was actually better. At this point in the United States, digital screen film mammography is essentially obsolete. So that's one important consideration when you're going for your screening or your mammogram. Make sure that it's at a facility that has digital mammography. In 2011, the FDA approved 3D mammography or tomosynthesis, and this has really been a great tool. It increases our cancer detection rate, specifically increases cancer detection rate for invasive cancers. So we're finding more invasive cancers when they're smaller, but we're not increasing our detection of in situ cancers. And the in situ cancers fall into that category of, well, these are the ones that a lot of people question, will this cancer ever become something I need to worry about? So with tomosynthesis, we didn't increase the number of the in situ cancers. We found the invasive, the ones that we know have the greater propensity to travel outside of the breast. It also decreases recall rate. So and I'm going to talk a little bit more about the technology, so those false positive events, this decreases the rate of number of women who call back, who are brought back for additional imaging, who don't end up having an abnormality. Tomosynthesis or 3D mammography, it's used in conjunction with traditional standard 2D mammography. The 2D mammogram is our roadmap. The 3D mammogram is a series of multiple low-dose x-rays that are acquired in an arc. If you've had one, you've seen the machine does an arc. A computer then reconstructs the data, and it allows the radiologist to scroll through the different levels of the breast to see through that tissue. Is there anything hiding, particularly in areas of dense tissue? And just so that everyone here knows, it's available at all Cape Cod healthcare facilities that provide breast imaging. And at the end, the resource slide with where you're able to get breast imaging through Cape Cod healthcare. So this is a standard mammogram. This is a 2D or your two-dimensional roadmap. And this woman has fairly dense breasts. And I read her screening mammogram, and I'm looking at her previous. This was her first exam that she had 3D mammograms. Wrong button, sorry. Oh, I cheated. I gave you the answer. So this area caught my eye. It doesn't stand out. It doesn't, and when I was looking at her priors, the architecture or the way the tissue pattern is in that, it bothered me a little bit, but really didn't look much different than many, many years of her previous mammograms. And that's one of the things we look for. How stable is a woman's mammogram? She had these are 4 slices of her tomosynthesis, so each of these was a single image. And this area here, which there's distortion or there's pulling, and this is a telltale sign of cancer. So for this woman, tomosynthesis was very important because I, as someone who's experienced, and I caught my eye, but I don't want to have false positive events. I don't want to cause women anxiety. It looked fairly stable, but this was an area of distortion. This was a cancer that really showed for me and solidified for me the importance of 3D mammography. The other tool that we use is, one of the other tools we use is ultrasound. It uses sound waves, there's no radiation, and it's used in conjunction with mammography. So what it does is, one of the things it does is help us, if we see a mass or a nodule on mammogram, it helps us determine what are the features of that. Is it something concerning or is it something benign? This is an example of a cyst. A cyst is like a water balloon. If you stuck a needle into it, it would pop. These are benign. Even though this is fairly large, this is about 4 centimeters, the way that this appears on ultrasound is 100% benign. this is not something that we worry about. On the other hand, this mass, it's oval, it's not black like you saw the other one. This is an indeterminate nodule. I'm looking at this and saying, well, it has benign features. It's smooth, there's not much around it, but this would have to go onto biopsy for us to prove one way or another if this was a cancer or if this was something benign. This is more of a representative example of what a cancer would look like on ultrasound. It doesn't have those smooth margins. It's white around the outside. It's got an irregular shape. This is concerning. When I see this, I'm highly concerned that this is a cancer, and this needs to go on to biopsy to prove that. The other tool that we have for breast imaging is MRI. It uses a strong magnetic field. There's no radiation. It does require an IV, and it's a long exam. It takes about 30 minutes. We don't use MRI. MRI is our most sensitive tool for finding breast cancer, but it also sees a lot of other things that may take up the contrast in the breast. So it can sometimes be like opening Pandora's box. So the studies have shown that using it in certain women, particularly women with a higher risk, greater than 20% lifetime risk of developing breast cancer, or in specific settings as a woman who's newly diagnosed with breast cancer that we're not sure if we can see it very well on mammogram or ultrasound or other factors that go into it. We do offer fast MRI at Cape Cod Healthcare. This is for women who don't meet the standard criteria for a breast MRI, that primarily being elevated risk, greater than 20% lifetime risk. But they want that extra screening tool, and they'll take the risk that they're going to have false positives. This is not covered by insurance companies at this point. This is something that's been it's been in the works for the past couple of years, particularly at the big academic centers. It's a much shorter exam. It still needs an IV, still has IV contrast. It's about 10 minutes. And it's pretty much, is there something abnormal? Is there not something abnormal? If there's something abnormal, you go on to having a full breast MRI in most cases. This is an example of what a breast MRI looks like. This is, for me, I love when I open up a breast MRI, it looks like this because there's nothing suspicious in this MRI. This is a 3D map of the breast that we get from the images. So this is the first study. These are the first images I look at when I look at the breast MRI. These are nipples enhancing here. All these squiggly things are blood vessels. This is the heart. Lungs are back here. And there's nothing taking up contrast in either breast. So this was a completely negative breast MRI. But when I talked about opening up Pandora's box, this is also a negative breast MRI. This is a lot harder to determine as a negative breast MRI because you see lots of enhancing little nodules on both sides. Fortunately, this patient had multiple prior breast MRIs, and all of these findings were stable. But this is an example of why we don't do this in every woman, because in many cases, if this were her first MRI, we'd have to go through and try and figure out what each of those findings is to make sure that none of them is a cancer. This is an example of what a cancer might look like on MRI. So this is a woman whose cancer was very hard. She had dense breast on her mammogram, and it was hard to figure out where the margins of her cancer were. So unfortunately, this was a fairly large cancer, and she actually shows us that the cancer had spread to her lymph nodes. One of the other areas that's advanced over the past several years is being able to do needle biopsies or minimally invasive biopsies for findings that we see that warrant biopsy. We can do biopsies under any of the 3 imaging techniques, mammography, ultrasound, or MRI. They're outpatient procedures. They usually take about an hour and a half to 2 hours, and women can return to their normal activities within 24 to 48 hours. Just another patient example of kind of putting all of these imaging techniques together. So this is a woman who came for a screening mammogram. Her breast, she'd had prior surgeries, she'd had reduction, she'd had a couple biopsies, and I only included the one side just for simplicity, but very complex mammographic pattern. She did have a tomosynthesis exam, and may not just project as well, but one thing that there's a mass that we can see on the 3D images that when you go back and you look at the 2D images, you go, yeah, there's a little bit of increased density there, but could really see that there was a nodule in that breast that needed further evaluation. She went on to ultrasound, and unfortunately, this was a cancer, a dark, shadowy, irregular shape. And she, because of how complex her breast pattern was, and we wanted to make sure we weren't missing anything else, she did go on to have a breast MRI. And this patient didn't project very well on MRI. Unfortunately, did have a breast cancer in the other breast, which we were able to detect so that she could go on and have treatment of everything at one time. But this was showing how that very subtle, this is the cancer here, very subtle mammographic finding, saw an ultrasound finding, and actually the MRI really gave us the best dimensions on how big this cancer was. Now I'm going to talk about our high-risk hereditary cancer program. So this is a risk assessment program for genetic predisposition to breast cancer, and it's actually not just breast cancer. In your material that you received in the bag is a card that talks about this program. It's a screening questionnaire that women are given to fill out when they come in for a mammogram. If criteria are met on that form for further discussion about potential risk for hereditary cancers, they're offered an appointment with Nancy O'Connor, who is our nurse practitioner who oversees this program. She's located in Hyannis. We also have availability of telegenetics consults, which are available both in Hyannis and Falmouth. If criteria for genetic testing is met and a patient is interested, it's available on site both in Hyannis and Falmouth. So what happens if you find out, for patients that find out that they are at an elevated risk of hereditary cancer? So if it's a risk, if it's a cancer, if it's a genetic predisposition to breast cancer, that puts a patient in a higher risk, greater than 20%. We're going to want to do more screening. What I mean by more screening is we're going to want to include breast MRI in their screening. So often what that means is that they'll have a mammogram, 6 months later they'll have a breast MRI, 6 months later they'll have a mammogram, so that we're looking at their breasts every 6 months. And we're using our two good modalities to make sure we're not missing anything. Some genetic mutations have predispositions for other cancers, like ovarian cancer or colorectal cancer. So we make sure that they have consultations with appropriate specialists and that those specialists know so that they can have discussions about what might be appropriate. We also are able to do a risk assessment for non-hereditary breast cancers. If you remember at the beginning, I said 75% of women who are diagnosed with breast cancer have no family history of breast cancer. So we need to be able to assess, there are women out there who have an elevated risk that isn't a genetic predisposition, but they still are at high risk for breast cancer. So Tyrer-Cuzick is a risk model assessment that the nurse practitioners in Hyannis and the navigators in Falmouth are able to do for a woman. And it looks at a variety of things, both personal factors and family history factors. And this is the model that we use to look for that 20% or higher lifetime risk. And if a woman falls into that category, it's getting the same consultations to make sure that if you're interested to be able to have mammography and MRI at alternating 6-month intervals. On this card, on the back, is the same link. There's an online breast cancer risk evaluation. It's not the at-depth one that you would fill out when you have your screening mammogram, but it's a preliminary survey. And if you would like to do it, and any of the factors are flagged that you would potentially be a candidate for genetic testing, it goes to Nancy O'Connor in Hyannis, and she will coordinate the appropriate follow-up. So that is in your bags if you're interested. So lastly, just want to talk about the resources available. As I mentioned at the beginning, all of this is available on Cape Cod. You do not have to leave Cape Cod to get these technologies. 3D mammography, as I said, is available at all Cape Cod healthcare facilities. Screening mammography is performed at 3 sites through Cape Cod Healthcare. One is at the Cuda Women's Center in Hyannis, one is at the Seaver Women's Imaging Center in Falmouth, and we also have a center at Fontaine Medical Center in Harwich, which does screening mammography. Diagnostic mammography, breast ultrasound, image-guided biopsy, and the high-risk hereditary cancer programs, those are all based at our 2 centers, the Cuda Center in Hyannis and the Seaver Center in Falmouth. And we also have breast MRI both at Wilkins, the Wilkins Center, which is right next door to Cuda, over by BJ's, and also at Falmouth Hospital. Other important numbers, and these are all on your slides, so that if you had questions or if you said, well, I want to maybe talk about testing, or even just to find out, what is my risk? How do you determine what's my lifetime risk? If you wanted to talk with one of our navigators or nurse practitioners about running a Tyrer-Cuzick risk assessment. The nurse practitioner's contact number and the navigator in Hyannis, as well as the navigator's contact number in Falmouth. And these are also 2 good resources for online resources of More information, the Mammography Saves Lives is a website put out by the Society of Breast Imaging, and there are interviews with experts in the field, some of the people who helped create tomosynthesis, very useful resources to look at. So we talked about four main things. We talked about screening mammography and briefly and touched about some of the controversial topics, the conflicting information. Bottom line, annual screening mammogram recommended starting at the age 40. We also talked about all of the different imaging technologies that are now available, talked about our high-risk hereditary cancer program, and then ended with some resources that are available.